Yo, welcome guys to another high-yield clinical medicine video section on this channel. In today's video section, we're talking about glucose 6-phosphate dehydrogenase deficiency, G6PD deficiency. If this video goes a long way to reward you guys, just leave us some likes, comments, or subscribe to join this wonderful medical family. As already stated, the topic for discussion today is G6PD deficiency. We first take this case scenario. Paul, a 28-year-old African-American male, presents to the emergency department with a 2-day history of passage of dark urine, generalized fatigue, dizziness, and mild shortness of breath. He denies fever, chills, cough, abdominal pain, or recent travel. He states that approximately 3 days prior to symptoms onset, he had been prescribed trimethoprim sulfamethoxazole for a presumed urinary tract infection after experiencing dysuria and increased urinary frequency. He took 1 dose of the antibiotic before discontinuing it due to the onset of his current symptoms. He also mentions that he had eaten a significant amount of fava beans at a family gathering about 4 days ago. He has no known chronic medical conditions and takes no other medications. He denies illicit drug use. Displayed here are the lab workouts done for Paul. By the end of today's lessons, we will get to know what the G6PD enzyme is. We will have a basic knowledge of the glycolytic pathway, the hexomonophosphate shunt. We will also appreciate how the deficiency of the G6PD enzyme clinically affects individuals. We will then relate this established knowledge to explain Paul's clinical presentation. G6PD deficiency is the most common enzymopathy affecting 400 to 500 million people worldwide. In G6PD deficiency, the body does not produce enough of the enzyme glucose 6-phosphate dehydrogenase. This enzyme is required in protecting red blood cells from oxidative stress. Therefore, lack of the G6PD enzyme leads to hemolytic anemia, where red blood cells are destroyed faster than the body can replace. G6PD deficiency is an X-linked recessive disorder. X-link implies that it is a genetic condition caused by a mutation in a gene on the X chromosome. Recessive means that the disorder only appears when there is no normal copy of the X gene to compensate for the faulty X gene. In genetics, males are associated with the X and Y chromosomes, while females are known to be having the X and X chromosomes. Let's take the males. Provided there is a mutation on the gene for the X chromosomes on males, and this mutation is responsible for G6PD deficiency, then it is clear that there will be no backup X gene to compensate for this faulty X gene, as the remaining chromosome pair is a Y. But for females, they have the X and X chromosomes. Provided there is a mutation on the gene on the one of the X chromosomes, fortunately for them, they have a remaining normal X chromosome, which can help combat or counteract the effects of G6PD deficiency. And this brings us to the conclusion that G6PD deficiency is more common in males than females. G6PD deficiency is an X-linked recessive inheritance, so it primarily affects males. However, it can affect females in rare cases, as females are mostly carriers. It is known to be the most common enzymopathy, affecting 400 to 500 million people worldwide. G6PD deficiency is more common in African Americans. For every 10 people that you take, you'll be having one African American having G6PD deficiency. G6PD deficiency is also common in the Mediterranean and Asian populations. G6PD deficiency provides some kind of resistance to malaria caused by the Plasmodium falciparum. Lack of the G6PD deficiency enzyme. How does G6PD deficiency offer some kind of resistance to malaria? Lack of the G6PD enzyme predisposes red blood cells to oxidative stress, and this can negatively impact the ability of the parasite to thrive. Again, G6PD deficiency may also lead to membrane damage in malarial parasitized red blood cells, making them more vulnerable to phagocytosis and their final destruction by immune cells. Can females get G6PD deficiency? The answer is yes. The first case scenario is when a female inherits two mutated G6PD deficient genes, one from each patient. The lady will be homozygously affected and will likely have severe G6PD deficiency with clinical manifestations similar to affected males. The second situation is a very rare scenario where G6PD deficiency can occur in heterozygous females through a concept known as lionization. More commonly, females inherit one normal and one mutated gene and are heterozygous carriers. Early in embryonic life, one X chromosome is randomly inactivated in each cell. This process is known as lionization. This creates a mosaic of red blood cells, some with normal G6PD activity and others deficient. So most carriers are asymptomatic. If X inactivation is skewed toward the normal X, the female remains asymptomatic. However, if X inactivation is skewed toward the mutated X, a larger proportion of red cells are deficient, and the female may develop hemolysis and clinical symptoms. Let's keep the concept of lionization simple and short. For a female G6PD carrier who has one normal X gene and one mutated gene which accounts for G6PD deficiency, in embryonic development, the body is programmed in such a way that only one of these genes is selected to bear up the full genetic responsibility. In a case whereby this mutated X gene is selected to bear the full responsibility, leaving the normal X gene, it will result in the production of more G6PD deficient red blood cells as compared to the normal red blood cells. This would then predispose the female to be having episodic crisis upon exposure to oxidative stresses. We switch the GA to the clinical biochemical pathway. The next question to ask is, where do you find the G6PD enzyme? Displayed on your left hand side is the glycolytic pathway, and on your right hand side is the hexose monophosphate pathway. Looking at this illustration, we find the G6PD enzyme here. We are able to make a deduction that the G6PD enzyme helps you take a shunt or a switch from the glycolytic pathway to the hexose monophosphate pathway. In the process of doing so, the coenzyme NADP is reduced to NADPH. Guys, this is the game changer. NADPH is taken up and fed into the glutathione pathway, where oxidized glutathione is reduced into reduced glutathione. What does the reduced glutathione do? Reduced glutathione reacts with oxidative radicals, example, hydrogen peroxide, in a process catalyzed by the enzyme glutathione peroxidase. This helps convert these oxidative radicals into water. This is the cell's antioxidant defense system, protecting it, including red blood cells, against oxidative damage. So this implies that in individuals who are G6PD deficient, there will be low levels of NADPH. This further implies that there will be low levels of reduced glutathione, which causes more oxidative radicals to build up in the body. And this results in RBC, red blood cells, destruction. When individuals who are G6PD deficient are exposed to oxidative stresses, there are certain offending agents which, when introduced into the body of a G6PD deficient patient, trigger hemolytic episodes. These agents introduce oxidative stress that overwhelms the already compromised G6PD deficient red blood cells. This leads to hemolysis and premature destruction of red blood cells. Sulfonamide drugs like trimethoprim sulfamethoxazole, anti-malaria such as primaquine and chloroquine, nitrofurantoin, dapsone, quinine, aspirin in high doses, and chloramphenicol are some drugs that can trigger G6PD associated hemolytic crisis. The most commonest precipitating factor is infections. Any severe infection can precipitate a crisis. Food like fava or broad beans can also cause G6PD associated hemolytic crisis. Naphthalene balls can also trigger G6PD associated hemolytic crisis. In the clinical setting, if a G6PD deficient individual comes in a hemolytic crisis, there are some basic laboratory investigations that you would like to run. First is the full blood count. With the full blood count, you like to look at the hemoglobin level so as to rule out any anemia. You also like to look at the platelet level because G6PD deficient individuals may come with bloody urination, which is hematuria. You would like to look at their platelet level so as to rule out any clotting disorder. Usually, their platelet level will be normal or within range. Again, we can also look at the reticulocyte count as matured red blood cells are being destroyed by the precipitated G6PD hemolytic crisis. Immature red blood cells are being formed in numbers, and these immature red blood cells are called reticulocytes. A kidney function test can be done for G6PD deficient individuals who present in their acute hemolytic episodes, particularly hematuria, as this episode can overwhelm the functions of the kidney and can cause derangement in parameters. So you like to run a kidney function test to assess the kidney functionality status or to rule out acute kidney injury. Again, a liver function test can be done for the individual so as to check their bilirubin levels. Also, a peripheral blood smear can be done for G6PD deficient individuals. The peripheral blood smear may show Heinz bodies, Bike cells, or blister cells. Heinz bodies are inclusions of denatured hemoglobin from adequate G6PD oxidative stress. Blister cells are red blood cells with a blister or clear area near the membrane representing the site where Heinz bodies are forming before removal. Macrophages in the spleen attempt to remove the Heinz bodies, taking bites out of the red cell membrane, and this leads to the characteristic bite cells or degmacytes. In the management of G6PD associated hemolytic crisis, the first thing is to discontinue the offending agent. You give supportive care by hydration, you transfuse blood in context of severe anemia, and then you avoid future oxidative stresses. Acute onset of hemolytic anemia symptoms after exposure to an oxidative stressor includes 1. Dark urine or hemoglobinuria. The patient may be jaundice. Patient may come in pallor, fatigue, feeling dizzy, dyspnea, or palpitation, which is a feel of the heart beating fast. Splenomegaly is usually not a prominent feature in acute crisis, unlike other hemolytic anemias. Now back to the case scenario. In the case scenario, you found that Paul, a 28-year-old African American male, presents to the emergency department with a 2-day history of dark urine, generalized fatigue, dizziness, and mild shortness of breath. He denies fever, chills, cough, abdominal pain, or recent travel. He states that approximately 3 days prior to symptoms onset, he had been prescribed trimethoprim sulfamethoxazole for a presumed urinary tract infection after experiencing dysuria and increased urinary frequency. He took 1 dose of the antibiotic before discontinuing it due to the onset of his current symptoms, which is the passage of the dark urine. He also mentions that he had eaten a significant amount of fava beans at a family gathering about 4 days ago. He has no non-chronic medical condition and takes no other medications. He denies illicit drug use. So in this case scenario, Paul has been well until when he started having dysuria, which is a burning sensation upon urination. So Paul visits the hospital and he's given the antibiotic trimethoprim sulfur methoxazole. And Paul indicates that right after taking just one dose of the antibiotic, he then starts peeing dark urine. So the question is, could this dark urine production be associated with the intake of the antibiotic trimethoprim sulfur methoxazole, which is a sulfur containing drugs? Guys, remember that in our studies, we've already highlighted that for individuals who have G6PD deficiency, whenever they are given sulfur containing drugs, particularly sulfonamides, that may trigger an oxidative stress and it may exhibit by the passage of dark urine. Again, Paul also indicates that he had taken fava beans at a family gathering about 4 days ago. So could this dark urine production be a synergistic combination of the trimethoprim sulfamethoxazole and the fava beans, triggering a hemolytic episode in a suspected male patient, in this case Paul? The other risk factor is that Paul is a male patient, and we have already established that G6PD deficiency is much more common in males than females. Again, Paul also gives a family history of his maternal uncle reportedly to be having a blood problem that caused him to become jaundiced after taking certain medications. Let's take a dive into Paul's laboratory workouts. For the complete blood count done, the white blood cell level is 8.5, which is within normal range. This tells us that Paul's recent hemolytic episode may not be associated with infection. He has a hemoglobin of 8.2, which also tells us that the ongoing hemoglobinuria may have been causing Paul to be losing lots of blood. Paul's platelet level being within normal range gives us a fair idea that the passage of bloody urine should not be associated with any blood clotting disorders. Paul's reticulocyte being slightly elevated gives us a fair idea that as red blood cells are being broken down, immature red blood cells are speedily being formed to replace the lost red blood cells. A peripheral blood smear reveals Heinz bodies, bite cells, and blister cells, which have already been discussed to be classical findings in a patient with G6PD deficiency. For the liver function test, the AST and the ALT are mildly elevated, and this is highly expected as Paul is jaundiced. Sickling test done for Paul is negative. HB electrophoresis done is AA. This further helps us rule out sickle cell disease, which can also present just as Paul's case with the passage of bloody urine. Now, the question comes, can we do G6PD enzyme activity assay for Paul? The answer is no. The reason is that Paul is in his hemolytic crisis, and when patients with G6PD are in their acute hemolytic crisis, doing a G6PD enzyme activity gives a false negative result. The reason is that as older red blood cells are destroyed, the remaining newly formed reticulocytes have higher G6PD levels. This will result in a normal or near normal test result, even though the individual has G6PD deficiency. So ideally, it is recommended you wait for a month or two after the hemolytic episode before you run the G6PD enzyme activity assay. Breakdown of the case scenario. So in this case scenario, you have an African male patient, no known medical illness, presents with dark urine, which starts shortly after intake of trimethoprim sulfamethoxazole, a sulfonamide, and a history of fava beans intake. He presents with generalized fatigue, dizziness, and mild shortness of breath. He denies fever, chills, cough, abdominal pain. There is no history of previous transfusion or jaundice. He has a history of maternal uncle, reportedly to have been having a blood problem that caused him to become jaundiced after intake of certain medication. Guys, this patient presents with an acute hemolytic anemia characterized by dark urine, hemoglobinuria, fatigue, dizziness, pallor, and jaundice occurring after exposure to an oxidative stressor, that is the trimethoprim sulfamethoxazole and fava beans. Laboratory findings of elevated reticulocytes in the red bilirubin, LDH, undetectable haptoglobin, and the presence of bite cells and Heinz bodies on peripheral blood smear are highly suggestive of an intrinsic red blood cell defect causing non-immune mediated hemolysis. The patient's African American ethnicity and family history of similar episodes with medications further point towards an X-linked inherited enzymatic deficiency, in this case, G6PD deficiency with acute hemolytic crisis. In your exams, look out for patients who become jaundiced and anemic after eating fava beans, developing an infection, or being treated with an anti-malaria medications. The underlying diagnosis may be G6PD deficiency. Stay tuned for other videos. If this video helped you guys, just leave us some likes, comments,